Great. Really excited to speak to Rubén King-Shaw to hear about his experiences during COVID-19. Ruben is a Cornell ILR alum of '83 and is the Chief Strategy Officer with Steward Healthcare System, where he's been since 2018. Ruben, thanks for joining us today.
Thank you for having me.
If we're going to talk about COVID-19 and your experiences and insights, but maybe before doing that, if you can just give us a little bit of information about your background, both in your role and prior to your most recent role at Steward Health.
Sure. Well, and thank you again for inviting me. Great topic. Happy to be with you. So I spent the last 2 years at Steward, all under the banner of being Chief Strategy Officer, which means a combination of two things. I had to go in, turn around one of our business units last year, improve the operations and sell it because we were leaving the market. And on the other side, it's figuring out a path for value and growth so that we can exit the investment. As you might know, Steward is a private equity owned venture, physician-led, management-owned venture. And like any other PE investment, there's a horizon to be an IPO or an exit involved. And so now I spend most of my time looking at the current environment, which obviously includes COVID, on the things that we have to do over time to build value in the company, return to profitable growth, deliver on our promises to patients, physicians, and payers, and then ultimately find the right path to exit. On the longer term, my career has always been a combination of private equity investing, business operations, and public service. That includes on the public service sometime, at the state level, as the state secretary for healthcare finance in Florida with Jeb Bush, in Washington, as a part of the George W. Bush administration, and then returned as an advisor for President Obama around value-based care and outcome-based care, chronic care management, fraud, waste, and abuse, those kinds of things. And then I've spent some time in and around Wall Street in terms of leading some companies to IPO, taking them public, and also leading a couple in the privatization, going the other way. So I've been around healthcare from many different vantage points: payer, provider, insurer, investor, corporate governance. So it's hard to find a seat I haven't sat in around the healthcare industry yet, but never a physician. I want to be clear, never.
Wow, that's fantastic. So why don't we dive in and talk a little bit about COVID? And the first question I want to pose, Ruben, is can you tell us a little bit about how COVID-19 has impacted your specific workplace, Steward Health, but also the industry in general? Clearly, you're in an industry that's been impacted greatly by COVID and has played a central role in our ability to address COVID. It'd be great to hear your thoughts on both, the experiences at Steward, but also of the industry as a whole.
Sure. And I'll start with the industry as a whole, but I think a lot of it is common, to what I would say about Steward. And that is the first thing that happened is people stayed home. When the message went out, sequester in place, stay at home, the first thing that happened is that the elective procedures that a lot of patients were going to have got shelved. Now, and that had a couple of implications. One, that's a huge financial impact for physician practices and hospitals. People might think that COVID's been great for healthcare business. It actually hasn't, because so many of the economics of the industry are based on those non-emergent procedures that hospitals and physicians do, and they dried up overnight. And the impact of that for rural hospitals, small hospitals, some community hospitals, even some rather large ones, has really been devastating. The effect also clearly was felt by physician practices. Many of the solo practitioners, had a very difficult time financially, and are still having a difficult time, for the same reason. Patients aren't coming in. And many of those smaller practices were already under financial pressure because of lowering pressure on reimbursement rates, or they had maxed out their credit cards to make ends meet in the prior cycle. And so it's been a very difficult time. On the other hand, you've got patients now who need care that aren't getting it, because the prioritization is obviously around your critical needs, your acute needs, and most certainly your COVID patients. And so having to convert wards to COVID, labor to COVID, space to COVID, give priority to COVID, all the right things to do, crowded out a lot of patients who, actually, if they wanted to get care, couldn't find it readily available because of the capacity constraints on the system. And in the long term, that's not good. An untreated patient is obviously a healthcare problem in the making, potentially, as life-threatening as any other. And so it's been a very difficult environment for healthcare in general, and that would include Steward.
Ruben, can you say something about sort of the impact on the workforce in healthcare, on frontline employees, and sort of the experience that Steward had with your frontline workers, doctors, nurses, and such?
Well, I like the term you use in some of your work, but we took a work-based approach to Steward. We have an extraordinary chief medical officer, and so the senior suite had calls every morning as COVID was developing action plans and responding to the latest information. And that included everyone from human resources to systems to our clinical team, finance, marketing, legal, all the business operations, you name it, all gathering around every morning on the phone, dealing with the issue. And one thing that was consistent was we understood the importance of protecting what we call our frontline workers. Now, yes, that's nurses and doctors, but it's also home care nurses and janitors, and it's the linen and it's the linen service, laundry service people, the CNAs, the dietitians, the orderlies. We understood very, very quickly that that's the first line, and they will have immediate personal impact. If we don't protect them with PPE, if we don't think about how we're going to deliver the care we need and keep our employees safe. And so we had a very disciplined approach, I think, to reaching out to organized labor when we could, where they were receptive, to game plan on how we're going to react to this crisis in a way that kept our workers safe, but enabled our workers to care for the patients that were coming in.
Great. So I guess that's a nice bridge into a second question I wanted to ask, which is about what you as an organization and you as a sort of organizational leader have done to help navigate through these difficult times. You've already touched on some of the efforts that you've done, but are there other measures that you've taken to navigate through this challenging crisis?
Well, one of the things, and I think we did this, I can't say better than everybody, but I think as good as anybody and perhaps better than most, is a regular stream of clear communication. I mean, we had a daily communication from the chief medical officer, sometimes from the chairman, sometimes from me as chief strategy officer, with messaging on here's what we know, here's what we have, this is what we're doing, this is what we ask you to do. And part of that was an uplifting message for all the workers, particularly the frontline workers I talked about. Part of that was just, the facts were coming in and the numbers were changing and the needs were developing. And, one could watch the news one day and come into work and think the sky is falling. And, and for many, it was falling. But we thought it was very important that we communicate regularly, and clearly, with facts, but also with compassion and support for the labor force at all levels, from the surgeons to all the way down to the janitors, on what we were facing and how we were responding. So I think our communication strategy remains a key part of that. We also made available through our EAP program support for our workers who were impacted by this too. In some ways, our workers are also our patients. And so clearly they were worried about their families being affected. Clearly we had some cases of workers, becoming infected themselves. The combination of fear for the future, fear about COVID, worried about the job stress that they had, we understood pretty quickly that there's a behavioral health portion to this that needed to be addressed. And so we made sure that people knew that we had employee assistance program resources available. And like a lot of healthcare systems, we had to reduce staff, and that was painful. And that's not the kind of thing that you do easily or do willingly. But the healthcare sector shed, I don't know how many hundreds of thousands of jobs over the last few months, and much out of just necessity. The economics were there. The government has come in and advanced Medicare payments and granted some funds and provided some relief. But this is still an expensive proposition, and so unfortunately, in all that environment I just described, a series of layoffs would obviously create some anxiety, and so we try to be very sensitive to that too.
Are there elements of the changes that you put in place, like the communication strategy that you described, that you think will sort of outlive COVID? Are there things that you've changed? Are there things that you've learned as an organization that you'll keep even when we're hopefully sooner rather than later past this crisis?
I mean, yes. I mean, and I'll give you maybe 3 examples. One is how we view technology, and we are looking at technology differently. So for example, you include in your work, I think, some excellent research on technology's effect on healthcare service delivery, what drives it, what decisions are around it, all those kinds of things. And so one of the things that we are looking at is ways to use digital strategies, social media, telehealth being among them, remote patient monitoring, and ways to reconnect the disconnected patient to the healthcare system, to their providers. Most of those technologies were originally implemented, to the extent that they were, as a cost management strategy or a demand management strategy. We actually think of it more as a reconnecting strategy to bring patients back into the system, which doesn't always mean back into the hospital or back into the physician's office. If we can deliver care digitally in a home environment that's safe, and now insurance companies are allowing us to do that, Medicare led the way. How long they will let us do that, we don't know. But right now, insurers are paying for it. But if you can connect somebody to the healthcare system and care for them at home, you can build back the relationship that was lost and provide the education that they need to safely return to the clinical setting when that happens, as opposed to starting that education when they need care, and that's too late. So we are looking at technology in new ways to build patient confidence and comfort and educate, not looking at it as it has been primarily a cost management or labor avoidance tool. That's really not the way we can see technology. I think another one is, we've connected the dots between COVID and some other environmental factors. So clearly, the Black Lives Movement and the uprisings and the protests, was another big jolt to the system. And we had to address that. And so one of the messages that I sent out, in fact, spoke about our corporate as well as our personal commitment, to eliminate healthcare disparities and inequities, and to stand up for human justice and the dignity of all humans in all neighborhoods. And so, it was important for us to understand that we're not just caregivers, but we're also employers. And we are employers in communities that are disproportionately brown and low income, not in every case, but in many cases. And so we could not divorce ourselves from the human experience of what was going on outside of our hospitals, because in many ways, the people who are working in our hospitals and patients in our hospitals were experiencing those social events the night before. And so I think we will remain connected to those dots, if you understand what I'm saying. That we have reaffirmed our commitment to the whole patient, the whole community, in a ways that I think healthcare systems always should have, and not always did. And then if I give you one more, it would be that eventually we will get this wave of patients that need to have their care addressed that they've deferred. And so we need to have conversations with governments and with insurance companies and provider partners on what is the new system going to look like to accommodate that. And so I think our forward-looking strategy is something that will be forever changed because of COVID, because I think patient and payer and provider expectations of what good care will look like and how we're going to pay for it have been forever changed.
That is so interesting, and sort of leads into this last piece that we wanted to hear from you about, which is, we're going through an uncertain time. No one knows what's going to happen next. But what are some of your thoughts on sort of where we go next, what the future holds, again, for the healthcare industry and for Steward as we try to come out of this crisis?
Well, I mean, a couple of broad strokes. This movement toward value-based care that everybody talks about, which is payment based on outcomes, not just fee for service, but outcomes, performance-based. I think that will gain tremendous momentum out of this. Because for one thing, we're spending a mint on this, and that's a bill that has to be paid. And so I think that it'll push further for policymakers to go down this road of outcome-based or performance-based reimbursement to make sure that the dollars are now being more effectively spent on quality of care. That's one. And Steward has been a leader in the value-based care movement. I think we will build up our resources around that issue, cost effectively, of course, but that's one. I would say that I think in general, and I don't want to be specific about Steward at this point, but I think in general, the industry will rethink the value it places on labor. And what I mean by that is, the demographic wave alone is driving home care and personal care and CNAs, all of those things. And the more the digital transformation of healthcare makes both patients and providers comfortable with delivering care digitally across distances at home, the more that home-based care movement is driven forward. And that will put stress on those traditionally low-wage positions, home aides and nursing aides and home health and CNAs and all that kind of labor at a time when we need it most. And so I don't think we can go bargain basement as an industry on that end of the labor pool in the future, because the demand will rise and we're going to need, I think, education programs or better educated people in those roles. There will be an investment for which there is an investment thesis that delivers a positive return on quality and on value. And so I really think that we're going to see some reshifting of the priorities in terms of the labor costs and investment in that front end, particularly home-based care, personal care part of the market. And if I have to do one more, I would say, I think organized labor has an opportunity here. I am a person that has been close to some unions over my career. We have a good, healthy, friendly relationship. They and I, in the most cases. That may not be true in all cases, depending upon the union at the time. But I would say that as workers return to work, it is as important for organized labor to care about the safety of those workers now as it has ever been. I mean, there are companies out there, I know one, which I'm happy to recommend to people, who has an excellent product, if you will, for surveying, testing, screening, doing the contact management, daily assessments, so an employer and the employee can know that they're COVID clear, for example. Because it's as important for the employer that those workers come back safely as it is for the unions to come back safely. And I think, joint efforts like Taft-Hartley plans could be some of the most innovative forces for change, both in terms of payment policy technology development, experimentation, all of those things. And I would encourage, those unions that think that way to get active on the issue, because I really do think it's a great opportunity. Pardon me. I do think it's a great opportunity for organized labor to have a huge voice in a positive way in the transformation of this industry, because it's coming.
You mentioned the sort of positive relationship that you've experienced in the past with unions in the healthcare setting. Are there examples of how a more collaborative labor management relationship in healthcare served to benefit the ability to face the pandemic, to face COVID-19? Are there examples of how that relationship within Steward actually enhanced some of the response? It's a leading question.
Yeah, I can't. Well, I don't want to comment on Steward in specific, because I'm sure we have conversations on the way, and again, it would be inappropriate. So I will speak in general terms, but I do think that balance of embracing innovation and technology and protecting the status quo. Unions clearly want to protect the jobs of their members. That's a part of what the members pay dues to do. I'm a firm believer in the scale effect of technology. I think what you refer to as the high road. I think you can embrace technology in ways that enrich work, build career development, add value. Automation, in the way we thought about it before, robots going to take my job, is, I think, actually a very small part of the discussion in healthcare. Because scientific advances of all kinds of healthcare hasn't made healthcare less expensive in general, and it hasn't stopped the labor pool from growing. So I think, coming to the table to be partners in innovation, pilot programs, that could be payment policy, it could be technological introductions, it could be robotics, it could be social media, but I think a labor management think tank, innovation lab would do tremendous good, I think, in the industry for all involved, including patients. And so I'm advancing that idea internally. We'll see how far I get. But I'm a huge fan of innovative collaboration in moments of crisis.
I love that, and I'd love to follow up with you as you continue in with those discussions. Is there anything that you wanted to share that I didn't ask you about? Anything related to your experiences in COVID that you think are important to share before we conclude?
I guess I would conclude with only this. The healthcare industry is going to grow at 5.5% a year over the next 10 years. There's plenty of demand, not enough supply for beds, buildings, hospital, you name it. And certainly not enough labor. So I would want for insurers and government agencies, hospital, physician leaders, organized labor, professionals of all types, to understand that this is a growing pie. There's plenty of work for everybody. And whereas I am not a fan of leaving every school district or every state or every city to fend for itself, as we've done with this COVID response, there hasn't been a coordination nationally. I think now, not in a top-down Medicare for all concept. That's not what I mean. But I think that there is an opportunity for large institutions that each have a stake in the game. To get over fighting over this zero-sum gain concept, understand that there's a rising tide here that will lift all ships or sink all ships. And so, let's start having conversations about value and synergies in the wake of this growth, so that, we're not sitting here, 10, 20, 50 years from now, when the system is completely broken or broke or both, wondering why do we squander such a good crisis? And you never squander a crisis. Never.
Great. Well, I think that's a good place to conclude. Ruben, thank you so much for taking the time to talk with us today. We're really excited to have your insights part of the hub. And thanks also for your support, your ongoing continued support to the ILR School. It's just greatly appreciated now and now even more than ever. So we really appreciate it. Thank you so much.
My pleasure. Thank you.